In India, the stillbirth is set if it occurs after 28 weeks of gestation. During pregnancy and labor. The rate of stillbirth in India is 14 per 1,000. The aim is to reach to 10 per 1,000 by 2030. Stillbirth cases may undergo little or no evaluation for possible causes of death. In some cases, the families are reluctant to undertake a workup since they perceive it will not make any difference. They feel uncomfortable with the name autopsy or genetic testing, or they have concerns about the expense. Despite these issues, it is critical to offer and encourage an evaluation for stillbirth. If a cause of death can be identified, it provides an explanation for the loss, brings a sense of closure, and facilitates grieving. Even if the cause of death is not found, the process of trying often brings comfort to the parents. In addition, families considering another pregnancy want to know the chance of recurrence, whether they can do anything to ensure a better outcome in subsequent pregnancy. The most important initial evaluation of stillbirth is thorough medical and obstetrical history. Some testing is recommended in all cases of stillbirth, and remainder of the evaluation may be guided by clinical circumstances of the stillbirth. Maternal medical conditions, symptoms, or part of obstetrical history will suggest possible risk factors, causes for stillbirth, and it should guide a focused and a cost-effective workup by the gynecologist. Pathological and histological examination. Gross and histological evaluation of placenta, umbilical cord, fetal membranes by trained pathologists is the single most useful aspect of evaluation of stillbirth and is considered an essential component of evaluation. A complete postmortem evaluation is recommended in all cases of stillbirth. Fetal autopsy is recognized by most experts as one of the most useful diagnostic tests in determining the cause of death. It can be full autopsy, but if the families are uncomfortable with complete autopsy, other options can be partial autopsy, gross examination by a trained pathologist, and imaging modalities like ultrasound and MRI. They may be useful. When a full autopsy is performed, published guidelines are usually followed. Genetic evaluation should be offered in most, if not all, cases of stillbirth. Acceptable specimens for karyotype include amniotic fluid or a placental block taken from below the cord insertion site, which includes the chorionic plate, an umbilical cord segment, or an internal fetal tissue specimen. Fetal skin is suboptimal. Tissue should be placed in a sterile tissue culture medium of lactated Ringer solution at room temperature. Chromosomal microarray is considered the first-line genetic test for stillbirth if the cost is not problematic. Fetal maternal hemorrhage testing requires identification and quantification of the extent of hemorrhage, ideally before the labor induction is started. APS testing or EPLA testing is recommended in many stillbirths, especially when accompanied by fetal growth retardation, severe eclampsia, or other evidence of placental insufficiency. If autopsy, pathology, or history of suggestive of infectious etiology, the evaluation should be undertaken. This may include maternal and neonatal serology, special tissue stains, and testing for bacterial or viral nucleic acid. Testing for maternal medical conditions should be guided by the history, the physical examination, and the clinical circumstances.